Hello, my name is Jay Wong. I'm a fourth year pathology resident in the United States. I only have like a week before I'm attending. Anyway, I go over cases almost on the daily from head to toe, different organ systems. So if you're into that, consider giving a like and subscribe. Without further ado, today we're going to use Johns Hopkins Pathology, Surgical Pathology Unknown Conference. And this is week 813, case 1. And it's a salivary gland mass. All right. So thank you to Lisa Rupert, Dr. Rupert, and Dr. Samuel Law. So this is a 75-year-old male with a hard palate mass. Select the correct diagnosis. All right. So we zoom in here. We see very basophilic looking cells that have somewhat nodular architecture with some in-between hemorrhage. We look closer. We see cells of the same cytologically, they all look the same. There's different architecture. There's kind of a gland forming architecture, or solid forming architecture. And I mean, there's a little bit of secretions, nothing like mucinous or anything. And the cells are pretty much, they're round, maybe a little nucleoli, maybe like a little groove there, but no intense mitotic activity, no intranuclear cytoplasmic inclusions. So again, more or less the same thing here. Some solid pattern, some glandular pattern. The question is if it's a cellular pleomorphic adenoma, mucoepidermoid carcinoma. I don't think it's mucoep because we don't see mucocytes. I don't see epidermoid cells, meaning like they look like epithelial cells. Adenocystic, I don't think this is adenocystic. I mean, you see glandular architecture, but they're not cribiform. And cellular PA, I'm between cellular PA and polymorphous adenocarcinoma. Given the various architectural patterns and that the cytology is same all throughout, given that I don't see a lot of prominent basement material or fibromyxillary like hyaline material, I'm going to go with polymorphous adenocarcinoma. And let's see if I'm right. Yes. All right, so also polymorphous adenocarcinoma is famously known classically, you see it in the palate. Histology. Histologic sections demonstrate an infiltrative mass arranged in cohesive lobules with faint myxoid areas and separating bands of sclerotic collagen. The lobules contain a variety of patterns ranging from cribiform-like to nested to sheet-like. Upon further inspection of the cytologic features, the cell appears to be of a single type. The nuclei appear mostly uniform, and there are few mitotic activities without any atypical mites. The cytologic uniformity, architectural complexity, and the characteristic palate location are in keeping with the diagnosis of polymorphous adenocarcinoma. Discussion. So polymorphous adenocarcinoma characteristically occurs in the palate of females in the 6th to 7th decades, although it may also occur in the minor and rarely major salivary glands over a wide age range. This carcinoma usually exhibits indolent behavior and is characterized by uniform cytologic features with diverse architectural patterns, most notably cribiform-like, solid, trabecular, and nested patterns. A characteristic growth pattern of polymorphous adenocarcinoma involves columns and rows of single cells infiltrating adjacent tissues, salivary glands, and extending to the overlying epithelium if present. Of note, cribiform adenocarcinoma is salivary gland. A variant of polymorphous adenocarcinoma, where a cribiform pattern is dominant, is associated with more aggressive behavior and a higher frequency of lymph node mets. It has been postulated in studies by Batsakis, Friedman et al. In the early 1980s that this neoplasm may be derived from the terminal duct of the salivary gland lobule. PLGA, polymorphous adenocarcinoma, and I think the LG stands for low grade, is characterized by molecular alterations in the PRKD gene, most notably in the PRKD1 E710D hotspot. Adenoid cystic carcinoma is a biphasic aggressive salivary gland neoplasia neoplasm demonstrating ductal and myoepithelial cell differentiation, commonly with a cribriform to solid architectural pattern. It is typically P63, P40 positive as opposed to polymorphous low-grade adenocarcinoma, which is P63 positive, P40 negative. In essence, absence of P40 staining in PLGA, which is a more sensitive marker of myoepithelial differentiation, reveals that PLGAs do not harbor myoepithelial elements and also highlights adenocystic carcinoma's biphasic morphology. Mucoep carcinoma is an encapsulated neoplasm with mucus, intermediate and epidermoid cell elements interspersed with columnar clear cell or oncocytic features and arranged in a solid cystic and sometimes papillary or glandular growth pattern. Lastly, cellular pleomorphic adenoma may, as the name implies, exhibit increased cellularity compared to a conventional pleomorphic adenoma. Identification of chondromyxoid stroma is key in the diagnosis. Well, there you go. Here we present a case of polymorphous low-grade adenocarcinoma. Well, I read the case, but presented by Dr. Rupert and Dr. Law, so thank you to them. And that is it for today. I will see y'all next time. Have a good one. Bye.